manifestations of this sleep that sometimes show up?
Well, sometimes there are many different situations where they'll go through the sleep itself, and of course they'll have different things that'll show up during the daytime, such as, and this doesn't mean that every child that has this problem will have them, but for example, sometimes they'll get up in the morning, they're lethargic, they have a hard time getting to functioning, it takes them 15-20 minutes to get the Fruit Loops down them, get the socks on them, and get them out the door. Or the teacher will say, gee, he's an extremely bright child, but he doesn't work up to his potential. Or sometimes they'll start things they don't follow through, or they have a daydream, or they have a lack of attention span. Well, that's a direct result sometimes of not going through those proper REM stages. And REM being rapid eye movement, of course.
That's the area of the sleep where we do most of our dreaming, is it not?
Yes, it is, and it's also the area where we basically rest psychologically and emotionally so that we get up refreshed and rejuvenated the next day.
Let's talk a little bit about Pacific International. You've been correcting bedwetting for 36 years. Dare I ask how?
Well, we have an approach that's individualized, and it's an educational, motivational concept to help that person overcome that sleep so that they can either wake up to bladder pressure and toilet themselves during the night, or else hold it, retain it all night until the next day, or a combination of both of those. And when that child or that person learns that, they're drying over the problem, and each one is different in how that's accomplished.
Is it easy to correct bedwetting?
No, it's not.
Can Pacific International correct any and all types of bedwetting cases?
No, that's the reason why that we have a selection process to make sure it's an acceptable type case. In the 37 years of helping children and adults with this problem, we have helped over 200,000 cases, and we average about 5,000 to 6,000 cases a year. But when we accept that case, we guarantee to stay with them until they're drying over the problem.
So the first step in a parent or anyone trying to find out what can be done about the problem of bedwetting, if they want some information from Pacific International, is to call 1-800-NIGHT-DRY, night spelled N-I-T-E, that's 800-648-3379. And of course, if there's no answer, you can call back the next day. Bedwetting must be a very frustrating thing for a parent to have to live with as well as the child.
Yes, it is. In fact, sometimes that's one of the more difficult parts about the problem, because many parents will go through many different things attempting to try to correct the problem, and all for naught, and it becomes very frustrating, and sometimes it puts a great deal of pressure on the child, but more importantly, it also puts a lot of pressure on the parent.
Do kids sometimes wet their bed on purpose to get back at the parent or something?
Well, I've been doing this for 24 years, and I have never discovered or been able to deduce a case where a child was actually doing that way. This is not something instinctually a child would want to do. It's just that they sleep too deep, and that circumvents the process or the ability to wake up, and consequently they wet. A lot of times the child becomes very confused because of the different things that's tried with them and the different pressures that's put on them, and consequently it may appear sometimes that might be the case, but I've never discovered one.
Why is it that we hear so little about bedwetting if it affects approximately 1 out of 6 people between 4 and 16 years of age?
Well, there's basically different reasons, but the primary one is that it's not a problem that's commonly talked about, and of course sometimes because there has been a history in the family, mom or dad or an uncle's had the problem, they sort of tend to live with the problem, and of course the thing is that many people just tell them not to worry about it.
Is it a social stigma, I suppose, too, that would prevent people from saying, well, my child wets the bed or whatever?
In most cases, yes. It's not something that they'll go down the street and advertise because they don't want to, whether it's pride of the parents or whether it's the embarrassment of the child, they don't want to have that be common knowledge.
What I'm hearing you say so far, the two main things that perhaps should be emphasized is, first of all, it's not the child's fault that they wet the bed, and that the bedwetting is a symptom of a sleep disorder. Is that correct?
That is correct.
Well, generally speaking, how has the medical profession dealt with bedwetters?
Generally, what doctors will tell most parents with this problem is not to worry about it. They'll probably outgrow it. And the reason they do this is because there's nothing physically or organically wrong with a child or an adult that wets on a habit basis. It's just that they're sleeping too sound and too hard and they can't wake up. That's the reason why that Uncle Sam still releases the men because of enuresis or bedwetting today.
If someone has a child who wets the bed or wants information themselves about this problem, and remember, it isn't just children who have this problem, it's also adults, they can call an 800 number. Why don't you tell us about that and what the people will get when they do respond to that number?
Well, the 800 number is 800 Night Dry, that's spelled N-I-T-E, and the actual number itself is 800-648-3379, and we'll be happy to send you a brochure which will explain to you many things about the problem and also how you can possibly get some help to get it corrected.
Well, if you've been dealing with this problem for 37 years with all ages, I imagine that you could tell a lot of stories about different situations you've come across. Is there one particular age or age group that's easier to correct than another?
Not really. The age of the child or the sex of the child, or often they're having the problem of enuresis, does not enter into exactly pinpointing how long it will take to correct or how difficult it will be. Each case is different depending on individual circumstances.
In other words, all bedwetters don't wet the bed the same, is that what you're saying?
That's true. We have cases, some that wet every single night, and then some wet as little as once a month or once a week, and there's a lot of variables in between there.
How about teenagers and adults?
Well, teenagers and adults are not treated any differently, except maybe for the sensitivity level, than a child that has the problem, because the same identical reason for it being there needs to be dealt with the same way in correction.
So if someone's wetting the bed when they're a teenager or an adult, it's still the same problem that they had when they were 4 or 5 years old. They're sleeping incorrectly.
That is correct.
This incorrect sleep that you talk about, besides the wet bed, I know Pacific International has been correcting bedwetting, what happens to that sleep when they go through the correction process?
Well, that's probably one of the most exciting things about getting a proper correction. If a child or an adult is corrected properly, not only do they get rid of the bedwetting so that they can go and stay and have friends over to stay and, be able to enhance their self-image, but also there's a great possibility that that child or the adult that's being dealt with will learn to sleep better and more normally. And that enables that person to be able to function better because they should be able to have a normal sleep arrangement and not be robbed of some of those REM stages that we mentioned earlier in the broadcast. They should be able to have a normal...
Well, it's easy to imagine, I suppose, that when a child gets over this problem, the difference it would make in how they feel about themselves. But if they're also getting a chance to benefit from a more normal sleep, there can be hardly anything but pluses on that side. Once again, while we've got time, I want to give out that 800 number. That's 800 Night Dry. That's N-I-T-E-D-R-Y. The actual numbers are 800-648-3379. By the way, does Pacific International do this on limited area basis, or where are you located, all over the country, or where?
No, we do this throughout the United States and Canada, and we can help people in any of those particular areas.
So anyone that wants that brochure mailed to them, call 1-800-NIGHT-DRY, N-I-T-E-D-R-Y, and Pacific International will send you that brochure, which will lay out some of the misconceptions about bedwetting and take a straightforward approach to what it is, and perhaps put you on your way to getting some help. We'd like to thank you, Mr. Draper.
This is Myrna Culberth of Read to Succeed. This week, mention KIEV and save $100 or even more on a family special at our 3 free seminars. Thursday night in Ventura at 7 p.m. at the Read to Succeed office, 4587 Telephone Road, the corner of Market Street. Saturday, 1 p.m. at the Hyatt Wilshire Hotel, Wilshire and Normandy. Sunday, 10:30 a.m. in Torrance at the Residence Inn, 3701 Torrance Boulevard, corner of Hawthorne Boulevard. Free autographed Star Trek books. Call 375-8938, 375-8938.
I'm a former service member. When I realized I could utilize my service skills, make extra money, get all the benefits, and fill a personal public service need, I called our California Army National Guard. I didn't want to waste the time and the experiences from my former full-time service, so I did something about it. If you're a veteran, too, this is your chance. Call 818-246-6447, and we'll tell you all about us. 818-246-6447, and maybe I'll see you around your local California Army National Guard armory.
KIEV, Glendale, Los Angeles, is everybody's voice. It's 7 o'clock.
The following program has been pre-recorded. No phone calls, please. Good evening, everybody. 7 o'clock in Southern California, and time once again for a visit with Dr. Kurt J. Wagner. Dr. Wagner, good evening to you.
Good evening. How are you?
Well, doing just great. We had a beautiful day in Southern California, and a lot of people getting outside, of course, enjoying the nice day. And you know, you reflect back on a day like this, and people are very concerned as we head toward the summertime, especially about their appearance, which is exactly your specialty.
Well, it surely is. You know, I always think that the inside and the outside should mirror one another. And today I thought we'd talk about something which is uppermost in many people's minds, breast surgery.
Yes.
The appearance of the breast. Now, let me preface this by saying that there are two kinds of breasts that I hope to discuss today.
Yes.
One is obviously the female breast, and the other one is the male breast.
The male breast?
Right. And many times the male is overlooked in discussing breast surgery. But perhaps we could start today with talking about the male breast.
You know, I think we should because, frankly, Doctor, I was unaware that there were that many significant problems in that area of the male body.
Well, you realize, of course, that we are sort of analogs of one another, and but for some hormonal changes and a turn to the right or turn to the left, we all have the ability to become male or female without the direction of the RNA that we have in our genetic structure, of course.
Yes.
Now, many males suffer from a disease called gynecomastia. Now, gyneco means female, so female breasts. And there are many, many men who have breasts that are kind of pendulous, female-like, and you would be surprised how many men avoid exposing themselves at the beach.
Well, I can certainly understand that, but Doctor, I basically thought that that was a problem that was inherent in just being overweight. But now you're saying that there's a different cause of it.
Matter of fact, if you will go back to your childhood and your adolescent time, I'm sure you probably recall, now that I jog your memory, that there was a time that your breasts were sensitive as we were developing our secondary sex character.
I would have to say in my pre-pubescent years, that was probably the case.
That's true. Now, what happens is that some of these hormonal changes go on to form a female-like breast, obviously not a hanging breast, but in some men, and particularly nowadays where so many people are interested in getting the quote and unquote perfect body, that even a certain amount of feminine characteristics to the breast will drive a lot of macho men kind of crazy. Now, it's kind of an easy procedure to do in that we make an incision around the nipple. We remove the breast tissue, which is actually hypertrophied or enlarged. And in some cases, the hypertrophy of the breast tissue has stimulated the body to lay down an overabundance of fat tissue as well.
Yes.
Now we're very fortunate in that in the last 5 or 6 years, fat suctioning has become relatively popular. Before, we used to have to dissect out this fat. And by removing the breast tissue underneath the nipple and then conforming the anatomical structure to the underlying muscle by fat suction and sculpting with the form of fat suction, and for some of my listeners, fat suction is merely the introduction of a tube which is attached to a hose which is attached to a suction machine, and by manipulation of this metallic or glass tube, we're able to form kind of tunnels in the fat tissue, and in that way, sort of like making a honeycomb, allowing the skin and the soft tissue to conform more to the musculature of the pectoral muscle.
Now, speaking of the skin following this procedure that you've just described, how long does it take for the elasticity of the skin to give the appearance of a normal male chest?
Well, it depends, of course, at what age and to what amount of hypertrophy or enlargement of the breast you're talking about. There are some males who have such large breasts, and incidentally, sometimes people who have prostatic cancer in later years get treated with female hormones, and they develop large breasts as well. But sometimes if you have to remove skin, of course, it's a different kind of a procedure, but usually within a couple of months it looks quite good.
Yes.
And it's a relatively painless procedure. Most men are happy to have it because the stigma associated with the confusion on the subconscious level and the feeling that people are going to make fun of them, of course, is unbelievably annoying to the majority of men who have had this condition.
Now, Dr. Wagner, is there any significant problem with scarring in most patients after this procedure?
Not if you have to make an incision just around the nipple. If you have to make an incision at the crease, the inframammary crease, which we call that crease where in the female breast it's easy to discern, particularly with a relatively well-developed breast, that crease underneath the breast, sometimes we get hypertrophic scarring, but usually for males it's not a big problem whatsoever.
So generally, overall, this type of a procedure in men will be successful?
Oh yes, we're not determining that it will be successful or not successful. We're just determining the degree of cosmetic improvement, whether it'll be more or less than 70, 80, 90% or so on. So perhaps dismissing the males, and if, of course, there are any listeners who have any questions, I'm sure they'll call in.
By all means, we are discussing breast surgery tonight with Dr. Kurt Wagner, who is a cosmetic surgeon in Beverly Hills, I believe, Doctor.
Close enough.
Close enough. Okay, West Los Angeles, actually. And if you have any questions for Dr. Wagner regarding breast surgery, the lines are open here at KIEV, and Dr. Wagner will be with us live all the way up until 7:30 this evening. If you have a question for the doctor, give us a call. Los Angeles, 628-KIEV. West Side, your number to call, 837-KIEV. San Fernando Valley.
The following program has been pre-recorded. No phone calls, please.
For your questions of Dr. Wagner, the number to call would be 989-KIEV. Glendale, Burbank, 956-KIEV. San Gabriel Valley, the line is open at 443-KIEV. South Bay, you can reach Dr. Wagner at 835-KIEV. And in the 714 area code, the line is open for you at 739-KIEV. Dr. Wagner, as you mentioned at the beginning of the program, obviously breast surgery in the majority of the cases involves women. What kind of cases are we talking about?
You know, in our society, breasts not only are sexual objects, but they're unfortunately a yardstick used in the evaluation of a woman, not only for male comparing with females, but unfortunately females comparing one another.
Mm-hmm.
And because of this, we can't assume that the breast is just a body organ, an appendage, although in the strictest interpretation it's really little else when you consider that the function of the breast is really only to nurse children. But of course we have given it a great deeper meaning,
yes,
psychologically and psychosexually.
Well, I think to a large degree because the time at which a girl becomes a woman is the time when the breasts will show their growth, when the change takes place. I think that's one reason for the symbolism.
Obviously, and of course, it's been extolled in literature and art, and it's a small wonder that we feel the way we do. Now, there are three basic categories that the patients who come to a plastic surgeon fall into. One is a woman whose breasts are too small. The other one is a woman whose breasts are too big or are hanging down a little too far. And of course the third one is unfortunately that woman who is requesting a reconstruction following the obliteration of a breast following cancer.
Yes.
So by far, at least at one time, it used to be that the vast majority of patients that I have seen were those requesting breast enlargement. Now, over the years, surprisingly, as the public has become more educated and more aware, the woman who requests breast reduction has come to the forefront. Pardon the pun.
I'm very surprised at that, Doctor.
Well, you know, breast enlargement is something that we can just discuss in this way.
Yes.
I'm sure we all know that basically what is used is a silicone kind of an insert, which is either filled with a silicone gel or a saline fluid. It is introduced into the breast either on top of the muscle or underneath the muscle, either through an incision around the nipple, through the nipple, under the breast, or under the armpit. There are many people who are advocates of one form versus the other. It is a successful technical operation. One of the problems with these enlargements is this, that number one, most people get some form of encapsulation of the breast insert.
Now, what do you mean by encapsulation?
Well, what this means is that the body recognizes this material as being foreign.
I see.
No matter how wonderfully well it has been produced. And it forms a layer of scar tissue around it to separate it, much as, for instance, if you had a pencil point, many children have fallen and gotten the lead pencil into their fingers or arms, and the body sometimes just tends to encapsulate it as it would a walnut, so to speak.
Mm-hmm.
So what happens is the body lays a layer of scar around the insert in order to separate it from the normal tissue. Now, that isn't so bad, because I don't have to tell you that obviously these inserts are small, soft, large, but they are made in the external state before they're implanted to simulate the feeling, texture, weight, consistency of the female breast. That stands to reason. Now, unfortunately, some people have a contraction of the capsule so that it contracts into the insert, forcing the insert to occupy a smaller and smaller and smaller space. And this results in the insert feeling firmer to the individual when it's touched or when you lie on it. And this is disconcerting to a vast majority of people.
I can understand that. Doctor, we have a call holding. What do you say we find out what our listener has to ask, and then we'll get back to talking more about breast surgery. Good evening. You're on KIEV with Dr. Kurt Wagner.
Hello. I wanted to ask Dr. Wagner about the difference when doing implants, the difference between doing them submuscular and subglandular.
Okay.
Is there any real difference in encapsulation or...
Yes. Well, let me just, that's a very good question, and it's a question that a lot of people are confused about. First of all, let me preface it to say that there's no right way or wrong way to enlarge the breast.
Mm-hmm.
The advantage to putting an insert submuscularly, of course, is that the constant contraction of the pectoral muscle sort of inhibits the insert from being encapsulated in too tight a space.
Oh.
Now,
so there would be less...
There would be less contracture underneath the muscle. The disadvantage is that in this particular day and age, there are many people who are intensive aerobic and bodybuilders. And many of these people occasionally are disconcerted because they have a feeling of fullness and discomfort when the pectoral muscle contracts. Now, 15 or 20 years ago, it was the rare woman who really cared about the development of her chest wall, except for the breast.
Mm-hmm.
Now, whenever I go to the gym, I see people jumping, pumping iron, and going absolutely bonkers.
Mm-hmm.
And that's one thing, at least in my experience, against placing it submuscularly. But there is no doubt that if you take an insert and place it submuscularly, you have a less of a chance of becoming firm. Now, there is an insert on the market right now, which I have been using for the last 6 months to a year more or less on a regular basis, that's coated with a special polyurethane.
Is that the MEM?
That's called the MEM, that's right. And my experience so far seems to be that you don't have to worry as much with encapsulation, because for one reason or another, I have my own particular reason for thinking of my own theory. Hello?
Doctor, apparently we got disconnected from that caller. If she'd like to call back, that's fine. Otherwise, I'm sure she is still listening, and you can go ahead and complete the answer.
Let me just finish with the MEM insert.
Sure.
The MEM insert, somehow, because of the polyurethane coating...
And she's back.
Okay.
Okay, go ahead.
Okay.
Okay, the polyurethane coating on the MEM insert seems to inhibit capsular contraction. And I have been very, very gratified with the results obtained so far. Let me just say one thing in passing, that no one can give you an absolute guarantee and warranty that these things are going to change, are not going to change over the next 10 or 15 years. I used to think that once you put one of these inserts in, they were there till the patient expired. It doesn't seem to be that way. There are some people who actually dissolve the outer capsule. There are some people who speculate that the body will dissolve the polyurethane foam. But by and large, these operations have been performed with one variation or another, at least for 25 to 30 years, and the vast majority of people are satisfied. I myself have done thousands of these procedures, and I can count on my hands and my toes the number of women who have requested me to remove these inserts because they couldn't tolerate them. So from a standpoint of patient satisfaction, at least aesthetically, it's very high. As far as theoretical satisfaction, for me, I of course would like everyone to look perfect and feel perfect.
I know, I've heard that's what I've heard about you.
Okay, so I'm very gratified that, at least for the time being, these inserts are getting better as far as manufacturing standards are concerned. And believe me, there's tremendous competition now among the various companies, and there are several companies that make wonderful products. It's just that don't let anybody, if you're considering this procedure, don't let anybody sell you a bill of goods saying that they have the foolproof method of doing anything. Because if everybody had the foolproof method, there would not be 4 or 5 different kinds of inserts out on the market.
That's what I was wondering about, yes. Okay.
Well, if you were a member of my family at this stage of my life, I would put MEM inserts into you, because I think that
But you would go subglandular?
I would go subglandular. Yes, I would.
Okay.
Okay?
Ma'am, thank you very much for joining us.
Thank Doctor very much for having me.
Okay.
And you are listening to Dr. Kurt Wagner here at KIEV, heard every Wednesday night at this time, 7 to 7:30 p.m. If you would like to call Dr. Wagner at his office, here is that number. It's area code 213-556-2746. Again, Dr. Wagner's office number, area code 213-556-2746. Dr. Wagner is discussing breast surgery tonight here at KIEV. And if you have a question for the doctor, we have lines open for you. Los Angeles, 628-KIEV is open. West Los Angeles, your number to call is 837-KIEV. Glendale, Burbank area, you can reach Dr. Wagner right now at 956-KIEV. San Gabriel Valley, the number to call is 443-KIEV. In the South Bay, the line is open for your questions about breast surgery at 835-KIEV. And in the 714 area code, you can reach Dr. Wagner right now at 739-KIEV. Good evening. You're on the air with Dr. Wagner.
Dr. Wagner, is a breast implant a long procedure?
No, actually, to put breast implants into a patient, which incidentally are done on an outpatient basis, it takes anywhere from a half an hour to an hour and a half.
Is that all?
Well, that's all it is. Now, what that means is for a week or so, the patient can't move around as gingerly as before, although there are some people who are sent out and active the first 24 to 48 hours. I tend to avoid that because, after all, it is a surgical procedure and you lift up planes of tissue. However, within a week, most people are doing relatively normal activities, with the exception of lifting heavy objects and doing aerobic and strenuous exercises.
What about the pain? What about the pain involved?
Well, it's an interesting comment. I'm under the impression, although I'm not a woman, obviously, that the pain is directly proportional to the mental imaging that a patient has.
In other words, it's all in the mind?
Well, there are a lot of patients who, unfortunately, have heard boogeyman stories about how painful this procedure is. And in truth, it depends on how big the bag is, so to speak, the skin bag is that you have to fill with. Obviously, if you have a mature woman who has had several children, whose breasts have gone up and down in size, and you have a little bit of loss of elasticity, there would not be so much tension on the skin when filling up the breast with an insert. Conversely, if you have a young virginal type of breast which has had no experience with pregnancy, sometimes for the first 24 to 48 hours, there's a certain amount of discomfort. Unfortunately, there are some breasts that remain partially numb for a period of time after the surgery. So obviously, by definition, what is numb cannot hurt. I would say this, that it has never been my experience, with well, maybe one or two exceptions, that a woman has begged me to remove these inserts because of the pain she's experienced. So that's not a big problem.
Well, that sounds quite easy.
Well, it's easy for me and easy for most of my patients.
Dr. Wagner, may I have your phone number and your address again, please?
Okay, it's 1125 South Beverly Drive in Los Angeles, and my telephone number is 213-556-2746.
And can I call any time?
Well, you can call any time. If you'd like to talk to me, I would suggest that you call during the daytime, unless you'd like to talk with my service. Okay?
Thank you.
And thank you for calling.
Bye-bye.
Thank you very much for joining us. That line is open, by the way, in the San Fernando Valley right now for your questions of Dr. Wagner, 989-KIEV. And in Los Angeles, the number to call is 628-KIEV. Dr. Wagner, we have not covered very thoroughly yet the topic of breast reduction.
No, we haven't discussed it at all.
Who are the ladies who are asking about breast reduction, and how severe are the problems?
Well, it depends. It's actually, it goes from a molehill to a mountain, so to speak. There are several young women who, in their development in puberty, develop enormous breasts, and it's called virginal hypertrophy. In fact, my daughter was one of them. And these people are very, very shy. They're afraid of being seen in public. And let me just say this, that women who have large breasts are not so blessed, because studies have shown that if your breasts are too large, you have irritation from the brassiere straps. I'm sure everyone knows individuals who have grooves in the clavicle areas from the weight of the breasts. You actually have difficulty in breathing.
Really?
Yes, put 10 pounds of weight on your chest and walk around on a daily, hourly, minute-by-minute basis, and try to imagine what pain and suffering some of these women are experiencing.
Doctor, I would have to imagine, too, that there would be tremendous discomfort after a woman reaches 50 years of age, let's say.
Well, there's tremendous discomfort, and as the skeleton is not able to support the weight, some of these people get actually a stooping of their shoulders, they get scoliosis, they get chronic neck ache and backache, and it's very interesting that the insurance companies realize that this is an anatomical and a medical problem, and many insurance companies will cover the cost of this procedure if it's done, and it can be verified. Now, they have a peculiar way of verifying if it's necessary, and that's usually by the amount of weight that has to be removed in order for it to be covered by insurance.
Now, doctor, are we talking about the same basic procedure where we have the liposuction in addition to some actual surgical removal?
Actually, what is done is we have a kind of a pattern that we use, and the lower half of the breast is usually removed, leaving the nipple attached with a skin pedicle, which is either attached to the front or the side or the bottom of the breast. and actually it's then reconstructed in the form of an anchor. It looks like an anchor, and it is a very, very wonderful procedure for most people. Many of these patients are very, very gratified. I do this procedure on an outpatient basis as well, although you will have heard stories that this procedure takes 3, 4, 5, 6 hours.
Yes.
Nowadays, I can say that with the increase in the number of people knowing this technique, that the surgery should take no more than 2 hours. There should be no need for blood transfusion. But just to give you an idea, a doctor, a colleague of mine, about last month, I watched her remove approximately 20 pounds of breast tissue from a 30-year-old woman.
Now, that has to be a very unusual case.
Oh, that's very unusual.
Yes.
Usually, the amount of breast tissue removed can go anywhere from 1 to 3 pounds, and that's an enormous amount of weight when you consider it on a daily basis.
Now, just so I understand this, Doctor, what is the material comprised of that you're actually removing?
You're removing glandular tissue, and you're removing fat and skin. And what you strive to do is to keep the nipple attached at all costs. In the older techniques, what we used to do was amputate the nipple and put it on as a free graft.
Yes.
Fortunately, in the last 20, 25 years, this procedure is only used for enormously large breasts, where you have no chance of keeping the nipple on a pedicle because the pedicle would be too long and the blood supply would be compromised. But this procedure is a relatively safe procedure. It is a procedure which frees a woman. You have no idea, unless you and I would care to walk around with these ankle weights around our necks, of how gratified these patients are. And it is an operation that I like to do. The problem with this operation, if there is one problem, is that the amount of scarring is difficult to predict. There are some people who have hairline scars, and there are some people who have thick scars. However, I would say that I would much rather deal with an individual who can breathe better, who can engage in physical activities, who can wear normal clothes, who doesn't have to feel that she's a sixth finger, so to speak, and deal with the scars, which can be ameliorated to a great extent.
You know, I was about to ask you that in the worst possible case, when there is breast reduction and scarring occurs, isn't there follow-up plastic surgery that can be done to greatly reduce the scarring?
Well, yes, and we can inject cortisone material into the scars, and very frequently that helps, and very frequently tincture of thyme helps a great deal too.
Oh, yes.
It is a wonderful procedure. It's something that I would tell people, not that I'm pitching for anyone to come to my office, but if you know of anyone who has large breasts and they by any chance don't realize that this procedure is available, it's readily accessible, there are a great many physicians who are capable and very well trained in doing this procedure, I urge them to urge their friends or family members to free themselves from really being in a kind of a body prison, as many plastic surgery procedures do. But that, of course, is for a different time. We're talking only about breast.
Of course.
Now, we haven't discussed, and I'm afraid our time
We have about 1 minute left, Doctor. That's about all.
We haven't discussed breast reconstruction for breast cancer, and in order to do it justice, perhaps we'll talk about it next week.
We probably should. We had calls tonight, and there is just so much to cover as far as breast surgery is concerned. But I think to sum it up, no matter what the problem is with the breast that we've covered tonight, there is no reason to have less than total optimism for a satisfactory outcome. That seems to be the basic thrust of your message.
Well, the thrust of my message is always this, that if you don't ask, you don't know. And that's what I urge listeners to call in, to ask questions. The questions we had today were salient. And I will say this, that I hope that the message is clear. You do not have to be a victim or a prisoner of your body image when it comes to breast surgery.
Dr. Wagner, thank you again for joining us. And for more information, you can reach Dr. Kurt Wagner at his office. Area code 213-556-2746. Again, that's Dr. Kurt Wagner, area code 213-556-2746. 46.
As a loyal KIEV listener, you can help spread the word about our informative and entertaining programming by placing a KIEV bumper sticker on your car. To get yours, just send a stamped, self-addressed, business-size envelope to KIEV Bumper Sticker, 104 North Glendale Avenue, Glendale 91206. That's KIEV Bumper Sticker, 104 North Glendale Avenue, Glendale 91206. Do it today and help other Southern Californians find out what they've been missing on KIEV. And now, moving right along, it's time for Read to Succeed with Myrna Culbreth. Let's bring Myrna in right now and say good evening. Good evening, Myrna.
Good evening, Dick Sinclair. How are you?
It's nice to talk to you. What's new and interesting in the reading business?
Well, among other things, we're going to have 3 seminars this week, which everybody can come to, and we're taking kind of a special theme on them this week. Not only do we tell what we're doing about our 18-hour reading course, but you and I have talked once or twice about the fact that if people are teaching reading by sight reading, as they have been for the last 50-some years, they may even be teaching it to the wrong side of the brain. And so this time we're going to have a seminar not only on our usual topics, but we'll go a little more deeply into left brain, right brain research, how you can use the whole brain to learn something that they may even be teaching to the lamer side of your brain for reading.
Well, that certainly is true, and now is a wonderful time to be able to change all of that, and you can do that, of course, with your procedure, can't you?
That's right, and the kind of interesting thing about it, as we've said on the air before, is it's so simple to change it, and yet it's so complicated if you don't change it. And many people are batting up against this problem all their lives, even though they may be very sophisticated and very bright and so on. Over half of our students now are more at the level of executive comprehension than at the level of any kind of even basic reading.
In other words, you're getting more adults now? Is that the idea?
That's right. We've always gotten lots and lots of adults, but also the kind of adult is beginning to include more and more people who realize it's not only for people who are in terrible shape, it's not just for basket cases, as we sometimes say, but it's for people who are very bright, very well employed. We have doctors, lawyers, engineers, accountants. Frequently people will come into our seminar because they're concerned about one person in the family, maybe a child or an adult that they know has some difficulty with reading or spelling. And before they're finished, they'll wind up enrolling the whole family.
You know, and I think a lot of time adults, too, are not good spellers, and you can help with that, too, can't you?
Absolutely, and probably over half of our students, when they come in, their main concern is spelling. They may have gotten to a survival level on reading, and that frequently happens, in spite of the fact that sight reading is as bad as it is. You know, by the time people memorize a lot of words and they smuggle in a little bit of phonics and they just are bright and they try and they work, they get many times to a level where the reading is not too bad. They don't notice the reading problem too much, but they notice the spelling. And if you can just take it to the bank, Dick, if someone does not spell extremely well and with great ease, they haven't been taught enough phonics.
So in other words, phonics can take you through the spelling and through the reading and the whole process. It's like building blocks for a house, right?
That's right. And once you have the tools and the building blocks to do this with, that's a very good analogy. You know, if you send somebody out, I sometimes say to kids or adults coming in, I sent you out with a pile of lumber and boards and nails and paint and so forth, and said, now build a house, but I didn't give you tool number 1, then you couldn't even get started. It would, you know, there's no place to go from there. You can't hammer the nails with your fist or chew the boards up with your teeth.
Well, you know, the obvious question again is, how did this disaster start?
Well, it started because people adopted a very, very wrong method of teaching reading, and they did it as far back as the 1930s, and they just flat made a wrong turn. The very best you can say is they made a terrible mistake, and one of the worst things you can say is they then would not give it up, no matter what evidence came in, no matter how badly kids and adults were affected by it, and they still have not. The Reader's Digest published an article only a little more than a year ago saying 90% of all American schools right now today do not teach reading by systematic phonics. I might add even the 10% which try to teach reading are frequently in the same boat as Cliff Ponder has said sometimes on our show. He's the man who's been a school principal for 20 years. He's out in our Ventura office. And he has said he never knew how to teach reading until he saw this method. Not only that, but he tried for many years. He was a school principal. He saw children going through his hands who were not learning to read. It finally drove him out of education because he spent tens of thousands of dollars trying to get consultants and others to develop methods that would succeed. And his teachers told him, but we are teaching phonics. And they were trying, but they did not know what we know to teach in phonics.
Well, it's an amazing thing. Yeah, I imagine this is one reason why so many kids become so discouraged and they drop out of school, right?
It's true. You know, almost all of the dropout rate, I would suspect, is related to reading failure. These days, there's almost no one so utterly poor that they couldn't keep a kid in school if the child could do well in school. And there's virtually no child who couldn't do well in our schools these days if he could really read well. And